Good afternoon, everyone. Claire, I'm in Dover. We'll give folks another minute. We don't quite have a quorum yet. Carol, how are we doing?
We have 4 right now.
Okay.
We have, besides yourself, we have Controller General Miller, Karen Rogers, and Tom Bracken. I'm going through the list to see if anyone else is on. Chief Justice is on.
Okay.
See Director Cade.
Okay,
We do have a quorum.
wonderful. Welcome, everybody. First, we'll start with introductions here in Dover. Carol?
My name is Carol Mick. I'm the Executive Secretary.
Good afternoon, Faith Runs, Director of Statewide Benefits Office.
Claire DeMatteis, Secretary of DHR.
Stephanie Hurtis, SEBC and Subcommittee Manager. Leanne Hinkle, SBO Deputy Director.
And Carol, why don't you go through who we have on?
Yep, so we have here in person Secretary DeMatteis, logged in virtually, Director Cade, Controller General Miller, Karen Rogers, Chief Justice Weitz, and Tom Bracken. Am I missing anybody that may have just logged in? Oh, I see the Insurance Commissioner.
Okay.
And Secretary Manning is on.
Okay, wonderful. Sean would not be joining.
Sean will, Mr. O'Brien will be joining late.
Okay. All right, well, let's go ahead and get started. We have a quorum. Welcome, everybody. First, I would like approval of our September 23rd SCBC meeting minutes. I have reviewed them. They were circulated in advance. Are there any edits? Not, I will entertain a motion to approve.
Motion to approve, Tom.
Thank you, Tom. Second.
Again, this is Josette.
Thank you, Josette. Any further discussion? All in favor signify by saying aye.
Aye.
Any opposed?
Aye.
Any abstentions? Okay, the minutes are approved. Thank you. We will turn now to public comment.
And Secretary, we did get the State Treasurer as well.
Oh, great. Thank you, Colleen.
Claire,
Yeah, good
for those minutes
They were good.
for public and executive session.
Well, let's go ahead and approve the ones for executive session too, because that's important. So, Tom Bracken, I'll clarify that those minutes were, as they were noted on the agenda, were for the September 23rd SCBC meeting. Now I will entertain a motion to approve the September 23rd executive session SCBC meeting minutes.
I'll make the motion to approve, Tom.
Is there a second?
I'll second Josette.
Thank you, Josette. Any further discussion? All in favor signify by saying aye. Aye.
Aye.
Any opposed? Any abstentions? Okay, the executive session minutes are approved. Now we'll turn to public comment.
I do not have anyone pre-registered for public comment today. It's there, and I see some hands raised, so let me get started. So we'll start with Bob Clarkin.
Hi, can you hear me?
I can hear you.
Good, thank you. I sent in some written comments, and I'm sorry they were so long. There were 14 pages of narrative and charts. And I'm not going to be able, obviously, to go over all that in 3 minutes. So I hope that if you have the time, the committee members would be able to find time to read my public comments. And I was hoping that the fiscal people that work for WTW might have a chance to take a look at them. And basically, what they're about is that I think there's a one-time opportunity because of the 27% increase in the premiums to finally make some adjustments and reallocations to the premium rates for Medicare retirees and pre-65 retirees. Because according to the WTW 5-year projection reports, during FY26, Medicare retirees should be generating a $26.2 million surplus. On the other hand, pre-65 retirees may be generating a 21.6% deficit. So I believe there's an opportunity to take the excess funds that the state is allocating to the Medicare side and reallocating them over to the pre-65 side, because those funds that come from the state and from retiree contributions total about $390 million. But if you could reallocate that excess to the Medicare retirees, there would still be a 4.6% surplus. So it wouldn't cost the state any more money to reallocate the surplus on the Medicare side over to the pre-65 side, and then take other steps to reduce the premiums that are associated to the Medicare retirees. And when you reallocate that over to the other side, then you would have a new basis to establish in FY25 to use to move forward in FY26 and rate each of the groups, the active employees, the pre-65 retirees, and the Medicare retirees on their own based on their experience.
Time.
And
Thank you, Mr. Clarkin.
thank you.
Thank you.
Next, we have Stephen LePage.
Yes, can you hear me?
Hear you.
Okay, great, thank you. I was looking at the programs that you guys have available currently, and I understand there's other programs that are being considered, but you already have quite a few programs listed, and some of them seem to be pretty effective. But I think what we need to have a basic understanding of is to get a clear picture of how well these programs are working, is that we need a comprehensive tracking program to look at three key things: the health outcomes, the costs, and feedback from patients. So for health outcomes, we need to track things like blood sugar levels, blood pressure, weight, to see if they're improving over time. And we need to see if people are sticking to their medications and whether they're avoiding hospital visits and serious complications, which tells us really if the program is helping them stay healthier. Secondly, when you look at costs, these include everything from medications and supplies and costs of doctor visits and hospital stays. And we also should consider costs related to running the program, like staff, training, and technology and materials provided to patients, so that we can tell if the program is cost effective in the long run. And lastly, we need feedback from the patients, because it's important to hear from them. If they're feeling better, do they think the program is useful? Are they able to make healthier choices? The feedback is necessary to understand if the program actually fits their needs and improves their quality of life. Combining all this data and the metrics, can help the SCBC and the SBO make better decision-making opportunities for programs to implement. Thank you.
Thank you. Okay. Next, we have Representative Bomback. Representative Bomback, right there.
This is muted. Representative Bomback, can you unmute?
Does that work? Does that work?
Yep, we can hear you.
Okay, sorry, thank you. Chair DeMatteis and other members of the SCBC, thank you so much for your service on the SCBC. Two quick notes, requests / questions. With the many pieces of legislation which are now law affecting the SCBC, I'd ask the SCBC to consider having their consultants rerun the long-term projections for the funding of future retiree health and to see how much we have narrowed that gap and the level of concern we need to address, and also to give us a base level to compare on a hopefully annual or semi-annual or every 2-year basis to see if we are coming along the projections that the oh shoot, what are they called? They aren't auditors, the other A word, do to estimate the long-term narrowing of that gap. So I think that'd be really helpful for the SCBC going forward. And shoot, I'll get to the second one in just a minute. But I may not. I think that's enough for now. And again, I want to thank you for your service. And I think the partnership between the RHBAS and the legislature and the SCBC has been very productive. And I thank you for your service. Thank you.
Thank you. Is there anybody else that's in the meeting that would like to make a public comment? Please raise your hand. If you're logged in over the phone, you can hit *5 to raise your hand.
No. We will move on to the director's report and subcommittee updates. Faith.
Thank you, Secretary. Just want to remind committee members that the state of Delaware Medicare open enrollment concluded this past Friday, the 25th. It was open from October 14th through Friday, the 25th. We did conduct for the first time for the Medicare open enrollment in-person and virtual events for an opportunity for eligible pensioners to come out and learn more about the Highmark Special Medicare Medicare Supplement Plan and their Part D pharmacy benefits available through CVS SilverScript. The attendance and participation at these meetings was extremely low. Therefore, unless there's objection by the SCBC, the benefits office is not going to plan to hold or conduct any in-person events as we start our planning for the 2025 spring open enrollment. In past years, we did do open enrollment in-person sessions for the active and non-Medicare population, usually just prior to and during that open enrollment period. Those were largely attended by our retiree population. Keeping in mind, Medicare retirees do make any decisions with regards to vision and dental benefits during that spring open enrollment. So in light of the surprisingly low attendance and participation and the cost, quite frankly, and the work effort around trying to plan those events, we've decided that we will not move forward with those for 2025. Other than that, the open enrollment for the Medicare retirees was rather quiet, ran smoothly. We stayed in touch with the Office of Pensions, who is the direct point of contact for any questions with regards to enrollment changes. The pension office did report that call volume was steady, but no issues or concerns. Most retirees were just simply calling to confirm that they didn't need to make any changes or submit any documentation. So the last open item that I have with regards to the Medicare open enrollment, the plan documents are posted on the website. They've been available since the start of open enrollment. The benefits office has completed the negotiations with Highmark on the MedicFill contract. That is being prepared as we speak for signature, so we should have that completed and fully executed by the end of the week.
Faith, just to comment on that further, that contract took a little bit longer than we had hoped, and that it usually takes. Can you give us any insights into why it took just a bit longer?
Yeah, absolutely, Secretary. That was really a consequence of, as the committee may recall, we've previously had one master services agreement in place with Highmark for both our non-Medicare and Medicare plans. As a result of the separate request for proposals for the supplement plan coverage, that required us to negotiate a separate contract. As part of the negotiating for that contract, there were also some changes in the standards around security and privacy of data that required a little bit of additional negotiating with Highmark. Some of those standards actually changed from the start of the open enrollment or the RFP process, that is. So it took a little extra time for us to work with the Department of Justice and the Department of Technology and Information on some of those changes. And then there were as well, just again, some provisions within that master services agreement, that larger agreement, that were not entirely applicable for the Medicville contracts. It just took us a little bit more time to work through those changes. But again, the delay was certainly in no way related to any of the provisions in the contract related to administration of the supplement plan or the plan design itself.
That,
Sure.
other questions for, you still have one to go?
Yeah, I just have a couple quick updates with regards to other committee meetings. The Health Policy and Planning Subcommittee did meet last Monday. That was the 21st. We did not hold a financial subcommittee meeting for October. There were two proposals discussed with the subcommittee at last week's meeting. Both of those are on today's agenda, so we'll continue that discussion with the committee today. Looking forward to November, we plan to hold a combined meeting of both the Policy and Planning and Financial Subcommittee. That'll be held on the 18th, with the full committee meeting being scheduled for Monday, the 25th. So for both of those meetings, we will be reviewing the fiscal year 25 first quarter financial reporting. And we hope to close out discussion on the two proposals that we'll be bringing forth today. To the extent that the committee is interested in moving forward with those, we would want to take votes at that November 25th meeting. We will also update the committee on the three requests for proposals that we have in process currently. So that's the flexible spending pre-tax commuter COBRA, the employee assistance program, and the accident and critical illness RFPs. We will open discussion on those three RFPs with the committee on the 25th, and we will be asking for your vote and approval on the proposal review committee's recommendations at your December 20th meeting. So that will be our last meeting for the calendar year. There are also, just as an aside, some ongoing discussions with the Lieutenant Governor about potentially convening the Retiree Health Benefits Advisory Subcommittee. We are circulating several dates for a November meeting, so those are currently under review, but we have not confirmed a date as of yet for that meeting. And then
That'd be after the election?
most likely going to be after the election because there is a 7-day posting requirement for the agenda. So I can't imagine it would be.
So that impacts the membership.
That is correct. It does impact the membership. So representative and co-chair Paul Bombach will no longer serve on the committee by virtue of no longer being an active legislator. And Representative Ramon as well.
And weren't some of the other appointments for 1 year?
I am not sure that there were 1-year appointments. I'd have to go back and check on that, Secretary. But we believe the other members on that subcommittee would still be in their roles and be able to participate in a meeting if one is held in November.
So,
Yes, we would certainly still have. Yes. And then the last thing I just want to mention, Secretary DeMatteis, you actually had suggested that perhaps for our November SCBC meeting, to the extent time allows, that we may want to update the committee on the latest OPEB report and valuation that was reported out to the office, to the pension board this past Friday, the 25th. So look for that as well on the November agenda, just for an update to the group.
Thank you. Carol, any other SCBC members join?
I did not see anybody else. It looks like we're just missing Sean O'Brien and the Lieutenant Governor, but I don't think she's gonna make it today.
Okay. Very good, just checking, thank you. Any questions for Faith? Commissioner Navarro?
If, hey, it's Ron.
Sorry,
Faith,
Ron, you go first.
who's going? I'm sorry. I apologize.
Yeah, go ahead, sir, Ron, go.
Okay. So Faith, I just wanted to point out, you're right. The actuaries did provide a report for OPEB. I guess we would reach out to pension board and see if they can come on in November. I think you want to highlight though that one of the representatives' requests was to make sure that they factored in as much of the legislation that was passed as possible. I think their actuarial report was mostly focused on the funded level, based on the contributions that have been made over the last few years, which, you know, is really good. It's increased from about 3% to really almost 11%, which is a really, you know, great over the last few years. But I think to the point, when we reach out to them, we should highlight the legislation and make sure that they factor that into their report.
Thank you, Director Cade. Yeah, and that could have an impact on, you know, I don't know that they would be ready to do that for the November meeting. So if it's the interest of this.
Yeah,
wait.
and maybe they're not ready, but we should just make sure that we put the ask out. But you're right. Maybe they're not ready, but we should definitely ask.
Yeah, I mean, in all fairness, that's the legislation impacts future reports on our OPEB. So yeah, in the future, of course, they're going to factor that in, but the snapshot in time that we're going to report on in November is for last year.
Right.
Commissioner Navarro.
Just real quick to Faith, one of your first comments about open enrollment for Medicare retirees. We should consider partnering with our office. We have the Medicare Assistance Bureau here, and we help people year round, not necessarily state employees, but just everyone who's either 65 or about to turn 65. And as you know, we're still in open enrollment, but it's something that's federally funded. We have the staff to do it. We have the expertise. So I'd love to have maybe I'll say conversation about it.
Commissioner, appreciate that. Thank you. We did engage with your team. There were information and handouts from the Medicaid Assistance Bureau at those events as well.
Yeah, I just think we maybe could do a better job of promoting it year round. Because as you know, people turn 65 throughout the year, and we send happy birthday letters to folks who are 64 in a couple months to prepare them for that. And I just think that maybe we could just do a better job promoting it. Thanks.
Absolutely, and I really appreciate that suggestion. Going back to the special Medicare contract and the relationship with Highmark for just a second. One of the things that was requested of Highmark as part of that contract award was that they would work more closely with the state on communications and outreach to the Medicare retiree population. So we are starting those conversations about what that engagement and those communications might look like. So to the extent we can also loop in, the support from your office, I think that makes complete sense. So thank you for the suggestion.
All right. We will move on to the financial reports and our Willis Towers team.
Thank you, Secretary.
Did get Sean O'Brien on by.
Okay, welcome, Sean. So where's Brian?
I'm here.
Okay.
Good
How are you
afternoon,
today?
everybody. Thanks, Secretary. I'm well. Hope everybody's good. So jumping right into the fund report for September, you can see in total that The total month of September ran about $1.5 million better than budget, with premium contributions nearly $2.4 million lower than budget, predominantly due to lower than expected state employee premiums, which is, we flip to this slide here, you can see it's now 2 months running that the state active employee premiums have come in lower than budget. We've done a bunch of digging into it. Part of it is due to the fact that there are certain employee deductions where payroll is not enough to cover the deduction, so that gets deferred to a later date and then ultimately gets excluded if those employees actually terminate before recoupment. As well as there's additional component in here from the teachers' side, where June premium contributions are larger than expected because there are certain employees that are on 10-month payroll versus 12. So we've got a little bit of an issue in the phasing, but this shortfall that we've seen in August and September by this group, we expect the gap to close. It looks like it's closed significantly in October, but we'll continue to monitor it. It might mean us updating the forecast a little bit to have this expectation that premium contributions on the state employee side are going to come in lower than expected for the balance of the year.
And Brian, that's lower than expected, even factoring in what we know about some employees who may have switched plans for lower premiums.
That's right. That's right. When we phased budget, we actually had FY25 open enrollment results. So the switching or the flipping from plans, particularly people moving out of the HMO into other plans, was already baked into the forecast. This was an additional piece as we started to try to reconcile the August and September contributions, where we uncovered those couple of nuances in the forecasting. From another revenue standpoint, pretty much right on budget for the month of September, about $100,000 off. Just one additional change to note there from prior results. This now includes the roughly $7.3 million payback to OMB from the transfer to keep the fund in a cash positive standpoint for the end of FY24. That was tracked outside of, call it, the normal categories of premium contributions, other revenues, claims, and expenses. But to be consistent with where it was bucketed in the fund report, as well as where it was bucketed in June at the end of FY24, those amounts were moved into the other revenues bucket. So this negative $4.0 million other revenues expectation now reflects the $7.3 million baked into it, and that it's consistent both from a budget and a tracking/forecasting standpoint. So it's just a modest change. Claims came in about $3.6 million better than budget. So if we take a quick look at claims, again, you can see in total claims came in at $105 million versus the expected $108.6 million. Part of that good news is actually driven by lower than forecasted GLP-1 utilization and spend. So you can see here, back when we set the budget, we had also actually known July's actual results, which was a 21% monthly increase versus June, the end of FY24. And if you recall, June had seen some very big month-over-month increases. So when we set the budget, while we assumed that the month-over-month increases would come down, we were still expecting higher than, call it, a leveled off rate in August and September, but actual has come in pretty good. August and September. August saw a 4% increase over July, and September saw a 2% increase over August. So not this 15% and 10% increases that we had baked into the budget. For now, our forecast assumes that October through the balance of the year will come in where we thought October and the balance of FY25 was going to come in when we set budget. But based on the last couple of months, if this trend continues, then theoretically the balance of the year will actually come in better than we expected. So not baked into the forecast, but at some point, maybe after a couple more months, when we see a little bit more of this hopeful leveling off of the GLP-1 utilization, we'll update the forecast. So that'll be potential positive news for the balance of the year against the full budget. So again, in total, September about $1.5 million better than budget. And you can see at the bottom, again, with those two caveats, one being on the state employee premium contributions, potentially coming in lower than budgeted for the balance of the year, but offset by GLP-1 spend being lower than forecasted. But as of now, the full FY25 forecast is almost spot on to FY25 budget. You can see a mere $30,000 different, with some categories being better and some categories being worse. Sean, you have a question?
Yeah, just going back on the GLP-1s. I mean, is there any discernible trend on the price of GLP-1s compared to what we expected? And I
No,
realize this is gross, right? So
Yeah, it's
Yeah.
gross. From what we had looked at from a price standpoint, pretty much all of the increases in spend have been driven by utilization, not by price. Now, having said that, I did not look specifically at September versus July, but we have the numbers here, right? We have 2,678 scripts in September versus 2,592 in August. So prescription scripts actually went up by a little more than 3%, whereas gross cost went up by about 2%. So again, just those 2 months in a vacuum, the average price actually came down a little bit. But generally, going back, looking at it historically month by month, it has not been driven by unit costs. It's been driven by utilization.
Okay, thank you.
Sure. Commissioner Navarro, I think you have a question.
Yeah, thank you. How do rebates factor into these costs, these projections? Are they already baked in, or?
So
Go ahead.
what you're seeing from a GLP-1 standpoint, as far as what we have on the screen, this is before rebates.
Okay.
So this is gross spend. From a claim standpoint, same thing, right? The claims are gross claims, and the rebates show up in the other revenues bucket. And the rebates are quarterly and they're lagged 3 months. So if you recall, back in August, we actually saw a little bit lower than budgeted rebate amount come in Q1 of FY25, which would have been rebates for the Q4 of FY24, but the rebates are tracked and accounted for separately.
So, forgive me for not completely understanding how that works, but should the numbers actually be better because because the rebates aren't factored into these?
The rebates are so when we go back to look at call it the holistic look, especially in terms of the total forecast, because September is not a rebate month for the fund, the rebates are factored into this row here, into the other revenues category. And to the extent that claims are better, rebates will be lower, because the rebates are a direct function of the specific brand drugs that are dispensed. So if claims are better, rebates will be lower. If claims are worse, rebates will be higher, but rebates are only a fraction of the total cost, if you follow what I'm saying. So maybe, I don't know if you want to maybe restate what the question is, because I know I didn't answer that so eloquently.
No, I mean, I think you did. It's just, if I'm looking at slide 8 and I'm looking at the, the claims versus projections, and if the projections are based off of the cost minus the rebates, that makes sense. I just wasn't sure if it did or if it did not.
Yeah. So this is gross cost. So for example, right, if we look at September in a vacuum, there was actually $3.3 million in GLP-1 claims for weight loss. where our budget assumed there would be 4 million. So gross claims are $700,000 better. But that also means that rebates will be some percentage of that $700,000 worse, or the net impact of lower GLP-1 utilization won't be 700,000, it'll be something modestly less than 700,000 net to the fund. Because again, these are gross claims before consideration of rebates.
Yeah, maybe,
And we don't
maybe
track
it's just-
rebates separately for GLP-1s.
yeah, maybe it's just me. I just have a hard time understanding that. And how that's actually factored in. So maybe we can have a sidebar at some point.
Okay.
I don't know if everyone else on the SEBC understands that, but, and if I'm the only one, I apologize.
Commissioner, no need to apologize. Part of the trickiness here is, CVS, doesn't have to tell us chapter and verse on the rebates. And that gets tough for us to do the math that you're trying to do.
Yeah.
I think the broader point, Brian, that I think the commissioner's getting at, and we're all trying to track is, we are definitely spending significantly more on these drugs than we thought we would when we approved the benefit. But what we can't as easily talk about is, yes, we're spending millions more, but that is reduced by rebates that we also are receiving.
That's correct. Just like any other brand drug, not specific to GLP-1s. But yes, that's 100% accurate.
Thank you.
Sean has another question.
Yeah, so I mean, just sort of following on Commissioner Navarro. My recollection is that for the GLP-1s, some of the math that was done looking at the last plan year seemed to indicate that, we are looking at GLP-1 rebates on the order of about 50%, right, as a group. So the net cost is, and I can't remember the exact math, but the net cost is going to put us like, if we spent, 3.3 million in September, we really are looking probably in the neighborhood of net spend of something like 1.65. I don't know. I know we don't know the exact number, but that's that's what we're looking at, what we're actually spending. That's probably on the order of that.
If rebates were 50%, then your example is right? We don't know what the exact rebates amounts are for GLP-1s. I think across all drugs across the GHIP, rebates are in the magnitude of 30%. So yeah, it's somewhere in that example between 50 and 70% of these numbers. But the point is that yes, the GHIP spend is lower than what is shown here because of the rebates paid on these drugs.
But we have been able to, for at least a one time, look at GLP-1s. So we do have some sense as to, right, we're not getting 20% rebates. They're much larger than that.
Correct. But they're not 50%. All right.
It can be 50%. They could be between 30 and 50% in general.
Other questions, comments? All right, Brian.
Thank you. There was a question last month, I believe it was from Chief Justice Seitz, about other potential indications for these GLP-1 drugs. So we have an additional slide in here that actually pulls 4 independent slides from a CVS presentation. I'm not going to go into the specifics other than it's pretty indicative that there are many other indications that are being considered relative to these GLP-1 drugs, which ultimately will mean potentially higher and higher utilization, because now they're not just used for weight loss and diabetes treatment, but potentially for other potential indications. So CVS has identified a pipeline of different types of indications that GLP-1s are being considered for. Let us know if you have any other follow-up questions specific to this. We'll likely have to go back to go back to CVS relative to those follow-up questions. From a long-term projection standpoint, we have 4 separate long-term projection illustrations in here. One being this first, where all groups, meaning active employees, pre-65 retirees, and Medicare retirees, continue to be all grouped as one aggregate population and pool, and therefore rate increases applying uniformly across all 3 populations. Based on that approach, again, this is reflective of the results through August. In order to achieve a $0 deficit after reserves by the end of FY 2028, we're showing a smoothed increase of a little bit more than 4% per year. This approach is only shown here illustratively. There's nothing that prevents us from having a single year rate action in each of the 3 years, FY 26, 27, and 28. It's shown here as a smooth approach simply because due to the 27% rate action that went in FY 25 on a single year approach, that would lead to a lower FY 26 rate action followed by somewhat higher FY 27 and 28 rate action. So for now, we're just showing a smooth approach to level that off over the 3-year period. When we potentially look at rating the 3 groups separately, meaning again, active employees, early retirees, and Medicare retirees independently, that 4.4% required rate action done in the aggregate would go up to slightly higher for actives alone at 5%, significantly higher for pre-65 retirees alone. So again, if pre-65 retirees were rated independently, that would require almost an 18% increase in their premium contributions, and then ultimately their own contributions to participate in the GHIP to 18% per year to produce their own independent $0 deficit by the end of FY 28, or said differently, retiree contributions would go up by a range of $8 on the low end for first state basic single, all the way up to $74 per month for FY 26 for comprehensive PPO family coverage. But again, that would be uniformly each year for the 3-year period, FY 26 to FY 28. And then Medicare retirees standalone actually would not require any rate action over the same 3-year period, and would still wind up FY 28 at the end of FY 28 with a surplus after reserves, and would not start producing a deficit on an annual basis until FY 29, which is not shown here. Additionally, we looked at one other potential rating class, which is not generally done by plan sponsors, where we looked at potentially rating active employees as one bucket and all retirees as a separate bucket, meaning combining the pre-65 retirees with the Medicare retirees, combining their experience. On that basis, the similar retiree standalone rate action would be in about the 2.5% range. But again, not something we would recommend, simply because it's generally not done that way by plan sponsors. And one other approach that could be considered is rating the Medicare retirees separate from everybody else, meaning combining active employees with pre-65 retirees, because those 2 groups are in the same plans. And interestingly, it's what many employers did once upon a time prior to the accounting standards that came out in the early 90s, which really started the path of employers looking at active employees separate from pre-65 retirees. But it is certainly something that could be considered as well, simply because they are in exactly the same plans. And I did a quick look at that this morning. And if you were to do that approach, again, the Medicare retirees would stay at 0, but from an active employee pre-65 retiree standpoint, if you were to combine them, instead of having a 5% for actives and an 18% for early retirees, it would be a combined roughly 6.5%. So slightly higher for actives, but much lower for pre-65 retirees. Again, with the logic being that they're explicitly and exactly the same plan options and plan designs. So let me pause there. I know in the past, the decision has been made to keep the rating the same, meaning aggregate all groups combined as one big rating pool. Is there any interest in the SEBC looking to explore separate rating groups going forward, something we should take back to the financial subcommittee to explore further?
Ryan, what's the financial subcommittee recommending?
They haven't recommended anything yet. We've only been sort of presenting these results because it's something we've looked at the past, and we sort of update the long-term projections, but there haven't been any explicit recommendations yet out of the financial subcommittee, nor have we asked them for an explicit recommendation.
I see no harm in asking for recommendations. I think that certain folks don't want to be included because of the impact their rates, and I just want to find the fairest way to do that. And maybe, look, I know the subcommittees are overworked now, especially with the RFPs and some of the things that they're working on, but I would love to see perhaps Willis Towers Watson and or the subcommittee come up with those numbers so that we can actually see them.
Sure.
Okay. Commissioner Navarro, as I understand it, and Faith and Stephanie can fill it in a little bit further, the financial subcommittee thinks this is one that the SEBC has to take. That they're looking for, recommendations from, maybe recommendations is too duplicative a word, but Faith and Stephanie, is this, if we handed this back to the subcommittee, are they just going to say, no, this is your job?
My interpretation of the discussions with the subcommittees, this is Faith Renz, is that the subcommittee is looking for specific guidance and direction from the SEBC on what specifically they should be evaluating. So I think they're viewing this more as a policy decision that should be initiated at the committee level for direction and guidance to them on what specifically you want them to explore further.
Okay. Chief Justice States.
You're on mute, Chief Justice.
There we go. I think I got it finally. So this strikes me. I just wanted to reinforce what was just said, that, this is really a policy question for the SEBC, and it's not something that we can just do from the seat of our pants right now. There is a lot that we need to factor in here. We ought to have a discussion and some time set aside for this discussion, because obviously the retirees have a point of view on this, and the current what we decide has a huge impact on the workforce and ability to hire and things like that. This is a really big question, and I don't mind having the data continue to be available, but I'm not prepared today to say one way or the other.
Thank you, Chief Justice Dyson. Just to be clear, this committee sets the rates in what, March?
No later than March.
No later than March. So the next iteration of the SEBC or our meetings in November and December with this current group, it's not a decision that has to be formally voted on until as late as next March. So to your point, Chief Justice Sykes, there is time, but this will be a very heated discussion for sure. Other comments? So I think we're going to have to, Willis Towers team, there's no, you can continue to map out. These are basically the two scenarios that as a policy, we would have to decide. Do we, number one, keep it as is? Number two, rate everybody separately. Number three, rate active employees and pre-Medicare retirees together, and then the Medicare population separately. Is there any other scenario that we should be looking at?
Not in terms of grouping. The only other scenario to consider is whether we use this smoothing approach as it's presented here, or we look at FY26, for example, in a vacuum and determine what rate action would be needed for FY26 alone to meet the financial criteria that we're looking to meet, and then FY27 alone, and then FY28 alone, as opposed to the smooth approach.
Yeah, I think that would be important to see.
Okay.
You know, if
So we
I'm,
can show all sets. Yeah, we can show both types of smoothing versus non-smoothing, as well as the different bucketings of the different cohorts as well.
sure, I think that'd be important to see, and certainly, you know, the pre-Medicare retirees have a vested interest in speaking up on this, because if we rate them separately, that's the group that gets hit the hardest. And you know, most Medicare retirees at one point were pre-Medicare retirees, so it's tough to make a change midstream here. I've always been a proponent of, I'll call it group health insurance plan for a reason. I am personally reluctant to make a change, but I certainly am willing to look at the data and to understand the options.
Yeah, and from an employee and retiree standpoint, you know, it's also important to note that we're talking about rate actions affecting total premium contribution revenue, whereas the employees and the retirees and maybe even a significant portion of the Medicare retirees are paying a fraction of that, and some of the Medicare retirees, the bulk of them are not contributing at all. So it's almost like you're looking at two things independently, right? One in terms of rating the overall required premium revenue increase needed to keep the fund solvent, and then what the implications of that are on the actual individual contributions as well.
Yeah, can we break that down further in terms of the Medicare population?
Sure.
Yeah, the actual number and percentage of Medicare retirees who do contribute anything. That would be anybody who retired after July 2020, 2012.
Yeah, so, and we actually have that on the one slide. So the a little bit more than 60% of Medicare retirees have a $0 contribution. And then the majority of the remainder have a 5% contribution, noting that the 5% increases for those who retired with fewer and fewer years of service. But again, the majority, 60%, don't contribute. The remainder contribute about 5%, which would mean that the increase would be in a range of, you know, $4 to $7 per month. But we can show those amounts explicitly. And what I'm thinking is, instead of having these separate long-term projections, which we'll still have for the details, that we put this more in a table form, just to see the actual implications of the different scenarios on the different populations and contribution amounts.
Stated differently, we would be looking at changing how we rate groups. You know, with a request of some state legislators and some Medicare pensioners, we would be looking to upset decades of how we rate this, literally to impact a couple thousand people. I think that's the kind of drilled down information that I personally need to make this decision.
Right.
I don't see how that makes any sense. You know, particularly that, let's face it, most of those folks in the Medicare pension group were once pre-Medicare retirees, and that's why we rate it as a group, so we balance each other out. That's a tough pill to swallow if you're a pre-Medicare retiree.
Yeah, clearly the pre-65 retirees are the ones that are most impacted by changing the rating methodology.
All right, so let's continue to work on the data and explaining who this impacts and how. And this group will continue to look at it in November, December, and then the next iteration of the SEBC will continue to do so in January.
Got it.
That-
Sounds good. And then if you recall back in, gosh, maybe it is going back almost a year. I think the last time we talked about this was in January. That the relationship of the benefit provisions themselves of the 4 options, meaning CDH Gold, HMO, PPO, First State Basic, has changed over time in relation to the rates, and more importantly, the percent share that active employees and pre-65 retirees pay of those rates to enroll in those particular 4 options are legislatively mandated. So what we did was we took a look at either realigning the rates themselves, realigning the benefit provisions of the plans, meaning the deductibles, copays, coinsurance, out-of-pocket limits that members pay in those plans, to have them align with the mandated employee shares of those options, or have legislative action that changes those mandated shares of employees to align with the premium. So a bunch of different levers that we could look at from a design or employee contribution standpoint. So resurfacing this whole conversation, you can see that we show actuarial values of the 4 options. And again, what's an actuarial value? Let's pick on CDH Gold. CDH Gold has an actuarial value of 97.8%. So what that means is that on average, for every $1 of healthcare consumed by participants, the plan pays 97.8 cents on that dollar, and the member pays the other 2.2 cents, again, in terms of copays, deductibles, coinsurance, out-of-pocket expenses at point of care. So the higher the actuarial value, the more comprehensive the benefit is. The lower the actuarial value, the less comprehensive the benefit is, meaning participants have more out-of-pocket costs in terms of deductibles and copays. So you can see the CDH Gold, Aetna HMO, comprehensive PPO, all relatively bunched together between 96 and 98%, with First State Basic being the lowest at the 91.6. The other big thing that jumps out relative to this is that over time, and again, because the CDH Gold has an HRA component on top of it, it actually is the richest of the 4 options. But the comprehensive PPO has the highest employee contribution. So when those contribution percentages were set, when that legislation was passed, it was believed at that time, and probably was true at that time, that the comprehensive PPO was the richer benefit, with therefore employees paying a higher percentage to get that benefit, versus the First State Basic being the least rich benefit, with employees paying the lowest share, 4% for First State Basic, 5% for Gold, 6.5% for the HMO, and again, 13.25% for the comprehensive PPO. But in reality, again, the Gold is the richest plan. So employees are only paying 5% for what is generally the richest plan, and 6.5% for the HMO, which is the second rich plan, again, putting aside that the HMO only provides in-network coverage. Mr. Bracken, I see you have your hand up. You have a question?
Yeah, Brian, one of the things that you hear from people that want the PPO is that there's a lot less headache with pre-authorizations and some of the other things that are available through that plan, but none of that gets factored into this actuarial value, correct?
That is correct, although I didn't think there, other than the HMO, which participants are required to use network providers versus not having any coverage out of network. I don't know that, it's something we'll have to go back and look. I didn't I don't know that there are different prior authorization requirements or restrictions between the first state basic, the gold, or the comprehensive PPO.
They all.
Brian, Brian, this is Faith. I would agree with that. Generally, those requirements are standard and the same for all of those non-Medicare plans.
They would require the same prior authorizations. So.
Yeah, there is an,
Baseline, Brian, what you're reviewing here is, and you've said this to us before, Delaware is very unique in that the General Assembly has put in code these limits. So what you're suggesting is another policy change would be to go to the General Assembly and ask for legislation to either remove these limits and let the SCBC set them or right size them.
that's right. So you're right. Either have the 4%, 5%, 6.5%, 13.25%, legislatively changed to align with the plan values themselves, or change the plan values such that they align with the 4, 5, 6.5, 13.25. And changing the plan design or plan values does not require legislative action. But you're right, changing the percentage shares, the employee mandated shares, does require legislative action. And we have in here a number of scenarios that do both. This is shown here just as a first step in that the rates themselves are not set comparably to how the plan design actuarial values are now today. So if we did that, meaning right size the plan values, don't change plan design, don't change employee shares, just right size the gross premium equivalents for each plan, that would mean that we would end up with a variable rate action by plan. So this ties back to the recall we were looking at roughly a 5% rate action in the aggregate in order to solve for that 3-year deficit, $0 deficit after 3 years. So in a 5% aggregate rate action year, if we realign the premium equivalents, do nothing else, don't change plan design, don't change employee share percentage, just realign the gross rates to be in line with the actuarial values, that would mean that the first state basic gold and HMO would see higher than a 5% increase, and the comprehensive PPO would see lower than a 5% because it had been rated as if the PPO was the highest value plan. So that's just a realignment of premium equivalents. And that's probably something we should do regardless of any decisions about plan design changes or changing state shares / employee shares, just realigning the gross premium equivalents.
And again, this committee would have to do that at the latest by next March.
That's right. That's
Okay.
right. But then we do, sorry, Secretary, did you have something else?
Treasurer Davis had a question. But please finish your thought.
No, let's let Treasurer Davis, because I want to go on to the next iteration next. Treasurer Davis, what's your question?
Yeah, it's a little bit more of a global question because it sounds like it would require legislation to make these types of changes, and we're talking about a $2 million total savings just based on where people are currently participating. Is that right?
So the $2 million savings, not sure where you saw the $2 million.
Here, so the state share, I'm looking at my own
Oh, I'm sorry, there it is.
slides, so
Okay,
I
you're right.
apologize.
So this would not be a savings, it would be an increase. So realigning rates and rebucketing rates would add an extra $2 million to the cost. just for
Okay.
realigning the rates themselves. But there's no
Okay.
change to the program design or the employee contribution percentages. It's just the realigning of the rates means you're ultimately collecting fewer dollars than otherwise would have been collected. Because as an example, comprehensive PPO contributions would be lower than otherwise needed.
Right.
But it's a
I'm just-
modest impact.
Yes, it sounds as though it's a modest impact, whether it's up or down. From, I understand what you would be doing is creating more equity across each plan,
That's right.
which makes sense. I'm wondering, just because I have faced the legislature and making attempts to get some substantive legislation passed, and sometimes that can be challenging. I'm wondering if it makes sense for us to utilize, value of, or I would say our ability to engage with the legislature, to utilize that time in to make potentially greater impact. And maybe this is a part of something that's kind of larger. And one of the things I think about is just sort of back to a survey, that was done a little while ago, and sort of anecdotal feedback from employees, that we may think about providing a different option to those that want to participate, meaning, potentially an HSA account and a high deductible option for employees. If we're going to go to the legislature, I'm just curious if it would make sense for us to go with a package of a couple of meaningful adjustments to our plans. And I will say, this doesn't seem to be quite as meaningful potentially from a, I think, to your point, it depends on what state employees are choosing year over year as to what that impact ends up being.
Yeah, and this first slide is really more of a, I'd almost call it a housekeeping step, right? Just realigning the whole rating structure to be based on the real relativities of the plans, as opposed to this uniform every year. If the overall premium increase is 27%, for example, as it was for FY25, that all gross rates go up by 27%, as opposed to the rates being realigned to where they need to be based on plan design. But to your point about more meaningful changes, I think you're right. I think there are a couple of things that, I hate to use the word should, that should be considered in terms of providing employees with the choice that's needed. And we tend to use this term meaningful choice, where generally we strive towards a meaningful spread in value of the options that participants have a choice of, as well as therefore a subsequent meaningful spread in the contributions that participants have to pay in upfront premium contributions to enroll in that particular benefit option. Or said differently, we tend to see a spread from high to low, where people have a choice of choosing a higher value plan with higher upfront premium contributions, and therefore less volatility in expenses if and when they should consume healthcare, or a lower value option that comes with lower premium contributions in exchange for a little bit more risk or higher volatility in out-of-pocket costs. So this better range from high to low, which we don't have in place today, right? Because the three options are all bunched together up at the top with First State Basic. While it's different in terms of value, it's not really a low option, right? All these options, if you liken them to the ACA exchanges, they're all platinum, right? They're all, whether you choose First State Basic or CDH Gold, you've got a fairly rich benefit plan. So something to consider is stretching the value of the plans to be a little bit more meaningful in terms of choice. Here, and this slide 23, gives just one example of what that might look like. So instead of having all of these plans in the 90s and 3 of them bunched up, maybe we have something that's, 80% on the low end with 5% incremental values from low to high, from 80 to 95. So somebody can still have this very, very high plan option available to them with higher upfront premium contributions, but also have a lower value plan. In fact, in the way things have basically stretched in this scenario, that would mean somebody could pick this 80% lower value First State Basic plan and have no upfront premium contribution. So a zero cost option to participants. And that's something I think that, to your point, is something that should be looked at. Whether these are the right numbers or not, put that aside for a second. It's more philosophically, is this the type of structure that we want? And then to your point about the HSA, I think you're right. It's something we've looked at, and it's something that we would certainly recommend potentially adding an HSA option. Today, the only way you could achieve it legislatively would be if you replaced the gold plan with an HSA option. But the gold plan is there specifically in terms of under an HRA option, which is what the gold is. You can have first dollar prescription drug coverage, whereas under an HSA plan, a high deductible health plan with an HSA, prescription drugs would need to be subject to that higher upfront deductible first. So if you were to offer an HSA option, it certainly is something that we would recommend looking at it as a 5th option potentially, just to protect that dynamic, but doesn't mean that somebody can elect out of the gold into the PPO or HMO or First State Basic and still get that first dollar drug coverage.
Brian, I am conscious of time, obviously an important discussion. Let's keep this going for the next meeting, but I'd like to move on now because for the next items on the agenda, we've bumped it a couple of times due to this
Sure.
very. So thank you for the level of detail. Any final questions on this before we move on? Okay, Faith, House Resolution 32.
Actually, I'm going to punt this over to Stephanie. Thank you, Stephanie.
All right, thank you. Good afternoon, everyone. This is Stephanie Hurtis, SCBCN Subcommittee Manager. Today, I'm going to be walking through House Resolution 32 and providing a brief summary of the programs and resources that the SBO offers to employees and members related to diabetes management and prevention, which you'll see ties into this resolution. Next slide. All right, so House Resolution 32 was introduced and passed by the House in June of this year. And this resolution strongly recommends that the State Employee Benefits Committee collaborate with a health system partner and a technology partner to deliver focused and targeted care protocols to a measurable cohort of GHIP plan participants, with a primary goal being to proactively address the growing problem of diabetes and metabolic syndrome in our population. The SBO has been working internally on a strategy to address the request of this resolution. We've been meeting with the state representatives who sponsor the resolution, as well as clinicians within our health systems, population health specialists, and Dr. Nancy Fan, the chair of the Primary Care Reform Collaborative, to determine best next steps. And overall, we determined that before the SEBC were to really take that initiative and dive into the process of developing and piloting another new program as recommended by the resolution, we wanted to take this time to evaluate the programs and resources we currently offer for effectiveness and improvement opportunities. So in August, the SBO released a report detailing our current diabetes and metabolic syndrome programs and services. This report has been shared with the meeting materials for the SEBC and is also posted publicly on our website. Next slide. All right, so starting specifically with the Highmark non-Medicare programs, we have 2 programs through the company Livongo. The first is a diabetes management program for those who have type 1 or type 2 diabetes. And the second is a diabetes prevention program for those who are pre-diabetic or at risk of developing type 2 diabetes. So starting with the diabetes management program, This program provides access to certified diabetes care and education specialists to help members manage their diabetes. They receive free glucose monitors and test strips while enrolled in this program. Currently, we have just about 1,000 members who are enrolled and actively participating in this program for the last 6 months. The share of members with controlled diabetes, which is what we want to see, it's a hemoglobin A1C of less than 7%, has increased from a baseline of 46.8% of those enrolled members to 73.1%, which is great. We've also seen members who had a hemoglobin A1C higher than 8. We saw a decrease of a 28.8% baseline to 11.9% baseline after those 6 months. So we are seeing success for members enrolled in this program to better manage their HbA1c. For the diabetes prevention program through Livongo, members enrolled receive expert-led coaching sessions for nutrition, behavior change and exercises. They also have access to a moderated online community where they can reach out to peers for support. This program offers an app and web dashboard for members to track their food, weight, physical activity, and they also can email and text their personalized coach to get real-time response and counseling when needed. This program, we've also seen some good outcomes, but unfortunately participation is very low. In the past year, we only had 18 members enroll in this program. Though of those 18 members, 72% received a 5% total body weight loss and 44% attained a 9% total body weight loss. We're working with Highmark to better promote this program to eligible members. And actually next month, November, is National Diabetes Month, and we'll be sending a postcard to all Highmark as well as actually Aetna members, advertising this program and our other DPP programs to better communicate what we offer and hopefully increase the uptake in these really great programs where we've seen some success. Next slide. So continuing with our Highmark non-Medicare programs, we also offer our CCMU, which is our Custom Care Management Unit program. While this program is not specific to diabetes or metabolic syndrome alone, it does offer health coaching and nurse support to help members get the support they need to manage chronic conditions such as heart disease, diabetes. They can use it to assist in weight loss and healthy eating when desired. We also have programs through them for smoking cessation, stress management, and other personalized care management opportunities where members can work with nurses, social workers, if they have social determinant of health needs that need to be addressed, as well as other providers to really meet the individual needs of the member and also increase member involvement in their own care. Highmark does also offer the Blue 365 discount program. This program offers a discounted gym membership, weight loss programs, discounts on massage therapy, and other services. However, as this is a discount program and it is not administered by the Statewide Benefits Office, we unfortunately don't have any data that is being collected or reported on participation metrics or results, since it really is just for discounts for those services. Next slide. All right, so turning to focus on our Medicare retirees. Through the Medicare Prescription Plan SilverScript, we currently offer the Transform Diabetes Care Program, which provides a holistic way to manage diabetes and overall health. In addition to glucose monitoring, this program provides personalized health coaching, which is based on the user's specific needs. So users who participate in this program have access to trusted advice on nutrition and lifestyle habits, as well as they receive reminders on appointments and screenings. This benefit is available at no cost to all AGWIP SilverScript members who have diabetes and helps address gaps in care that may be identified. So just a few quick statistics on this program. About 25% of all SilverScript members are eligible due to having a diagnosis of type 1 or type 2 diabetes. Of those members, 94% were identified as having gaps in their care. So gaps in care can include a variety of things. So it could be a gap in medication adherence, screenings for prevention or even cancer screenings, medication optimization, comorbidities, self-monitoring, and even access to devices such as a glucose monitor or blood pressure cuff. In the last quarter of fiscal year 2024, the Total Diabetes Care Program closed just over 2,000 gaps in care for these members, but with the majority of gaps being closed in medication adherence, preventative screenings, and medication optimization. I did want to call out, it's not included on these slides, that Medicare does offer also a diabetes prevention program. This program is not affiliated with or administered by the state of Delaware, though Medicare members can search on the Medicare.gov website for program locations near them and to see if they qualify. And this program is entirely free. It is specifically through Medicare. And the SBO during the Medicare open enrollment that we just closed last week, we did promote both of these programs, both at our in-person sessions and through the materials on our website. So before I move on to the Aetna programs, are there any questions so far on what we went over for Highmark members? All right, next slide. All right, so moving on to our Aetna members. Aetna also offers the Transform Diabetes Care Program, though it looks a little bit different than what we offer for our SilverScript plan. This is a 12-month program that helps members manage their diabetes and provides customized guidance based on the individual needs of the member. So members can use the CVS Health Tracker app on their phone to plug in and monitor their glucose and blood pressure. They can track and share readings with their medical providers and coaches. They can read up and learn more on diabetes and lifestyle management. There are recipes on there to help meet their dietary needs, and they can get that personalized support from a certified diabetes care and education specialist, as well as diabetes specific nurses. So anyone managing diabetes who has an Aetna plan is automatically enrolled in this program, which is about just over 7% of all Aetna members. So in order to engage members in this program, Aetna sends out welcome kits to those who are eligible. So for context, last year, Aetna sent over just over 2,000 kits, with 90% of those members having received a secondary outreach to really bring more people into the program. 82% of all members who are enrolled in this program have an HbA1c level of less than 8, which is considered controlled, and so that's really what we want to see. Next slide. As far as diabetes prevention through Aetna, we offer the Solera program. So this program is designed to help members lose weight, adopt healthy habits, and reduce the risk of developing type 2 diabetes through participation in a very personalized program. So like the others, this is a 12-month program, and it includes 16 weekly sessions followed by monthly sessions with a lifestyle coach and small group support. Members have an option of doing this program in person or virtually. There is no cost, again, for this program. And actually, for members who enroll and complete the first 4 weeks, they get a free Fitbit, which is a fitness tracking device that you can wear on your wrist. In fiscal year 2024, we had 532 Aetna members enroll in this program, and about 30% of those enrollees achieved a weight loss of at least 5%. Next slide. All right, I'll just very quickly touch on this. With Aetna, we also offer the Able2 Behavioral Health Treatment Program, as well as Aetna One Advisor. These are free resources to help Aetna members manage their health, coordinate care, meet their goals. Very similar to what we actually just addressed with the Highmark CCMU program. And members who are interested in receiving this level of care or care management, they have the phone number on the back of their Aetna card for Aetna One Advisor. And of course, there's more information posted on our website about those programs. Next slide. I believe was there a slide that was skipped? Okay, thank you. The YMCA program, yes. So with Highmark and Aetna, for both Highmark and Aetna non-Medicare members, they can also participate in the YMCA's diabetes prevention program, which provides a supportive environment in a small group setting to learn how to exercise healthily and adopt healthy habits to reduce their chances of type 2 diabetes and lose weight. This is a 12-month program with 25 one-hour sessions in a classroom setting. Typically, this occurs at a YMCA branch, community site, or even some workplaces. And a trained lifestyle coach teaches participants skills that really help them lead that healthy lifestyle and give that one-on-one support that is really often needed. As an added benefit to really encourage members to participate in this program, the SBO actually provides 4 free months of a family membership at the YMCA of Delaware. But still, even with this additional incentive, in the past year, fiscal year 2024, we only had 145 members participate in this program. 20% achieved just that 5% weight loss, and 30% achieved a 9% weight loss. Next slide. Alrighty, I'll just go through these real quick. We also offer the Husk Wellness Program to all Aetna and Highmark non-Medicare members. This program specifically has gym discount options as well as discounts on fitness technology and equipment. So if a member wanted to buy a treadmill or a weightlifting set for their home, they can go through Husk Wellness and get a discount. We also offer gym discounts in all 3 counties. We have a list of participating gyms on our website that members can access. And also just wanted to very quickly call out our employee assistance program through ComPsych. This is a free program that offers confidential emotional support by highly trained clinicians. Members can also get guided programs for anxiety, mindfulness, fitness, and nutrition. And also non-Medicare employees, spouses, and dependents receive 5 free therapy sessions with this program prior to even being billed to insurance. So always want to plug that resource as well. All right, I know that was quick and there's a lot of information in there. We do have the full report that was sent to all members and is posted on our website. Very much encourage everyone to take a look at that and also take a look at the programs that we offer. Sean O'Brien, it looks like you have a question.
Yeah, if we could go back to the House Resolution 32 slide. I mean, can you say a little bit more about what we think it means, especially when it comes to the urging the SCBC to collaborate with a health system partner and a technology partner? Do we know what is intended by that? What's a health system partner? What's a technology partner?
Sure. So a health system partner, my understanding of the way this bill was written, or this resolution was written, however, would be a health system in Delaware, such as ChristianaCare, Bay Health, or BB, to really integrate the health systems into a more holistic program. So something that you'll see with the programs that are currently offered, not really even just through the group health insurance plan, but in other programs as well outside of the state of Delaware, is they tend to be very centered and there's not a lot of sharing of information to a provider. So say a member is enrolled in our Livongo diabetes prevention program, their PCP doesn't get any data or metrics related to that program. The goal of this resolution really is to have a more holistic approach where providers, the groups themselves, such as Livongo, as well as a technology partner, which we have not really explored. There really is no funding at this time to explore a specific technology partner to that extent. There are a few options that were thrown out for that, such as continual glucose monitoring, Fitbit tracking, things like that, a fitness watch, where the provider, the member, and any health coaches would be working in tandem to address the needs as opposed to the current structure, which tends to be working in silos, if that makes sense.
Yeah, I guess. Go ahead.
We're going to get into a little bit more of the next agenda item of I think, to address your question.
Okay, I was just going to say, I guess I don't quite get the health system partner piece of it, because if we're talking about making sure primary care physicians are connected, for example, somehow with these programs, unless they're employed by a health system, like Christiana, I guess I don't understand how those pieces fit together. But you don't need to answer that. I know we have more to get through on this, and probably miles to go before we get to a strategy. So
that's correct. I appreciate your feedback. You're not the only one that has that view.
Thank you.
Just what the team's been working through. Do we want to move to the next agenda item on enhancing the diabetes program? Obviously, that we thought it was really important for this group to understand what we already have been doing. As you know, reducing diabetes and the costs and helping our employees stay healthier who have diabetes has been one of the strategic frameworks for the SCBC now for a number of years. And we thought it would be helpful to summarize those programs before we dive into enhancing it.
Sure. All right, well, I would like to introduce you to Matthew Swanson, the co-founder and CEO of Reciprocity Health. Reciprocity is a partner of Highmark Delaware and has worked with the Delaware Medicaid program on a Healthy Rewards initiative. Today, they'll be here presenting a pilot proposal specific to the group health insurance plan that focuses on using incentives to increase utilization and outcomes specific to the YMCA Diabetes Prevention Program, which we just highlighted. This program would be a pilot that is specific to Highmark non-Medicare plan members who are active employees of the state of Delaware. Matthew, you should be able to share your screen and begin going through your presentation.
Great, thanks. I'll pull that up now. Did that come up for everyone?
Yes.
Okay, great. First, let me say thank you for the opportunity to speak today. I know several of you from work going back 10 years in healthcare, BCHI and the CMS funded work around bringing value-based care to the state. I'll work through this quickly because I know there may be some time constraints, but please have anyone interrupt as we go through. In fact, the work that we did here in Delaware for 10 years really brought to the forefront the fact that to make value-based care work, to make the healthcare system overall work, you really need to have very active and participating patients to drive the proper outcomes and costs associated with those outcomes. And we built this company to try to activate those people who are harder to reach or have reasons for which they are opting out of their care and end up in the long run costing a lot more money and having worse outcomes. So really trying to build a bigger population of active patients in their care was really the goal. So our company really focuses on behaviors and decisions related to healthcare, and the other condition in the system that needs to be recognized is that it's not always easy to make health decisions that will benefit you in the short or long term, and that the social determinants of health really are a huge factor to that. So in this chart on the left, medical care, excellent medical programming can only get you so far. It is really the patient's behaviors and decisions as they go forward and what they face in their day-to-day to keep participating in those programs that really drive an outcome and the cost associated with that outcome. And it's not, the non-adherent population is not a monolithic, stubborn population refusing medical care. These are folks in everyday life that have an assortment of different challenges. And what we're trying to do is create a friendlier on-ramp to care, a more inviting way for people to not be intimidated, to come forward, put a tailwind behind their care so that when they show up and are participating, we are bringing them along the way in an encouraging and a motivating format that allows them to, what we see, driving much higher levels of adoption of programs to begin with, and then adherence throughout that care journey. So the company was really based on CMS field-tested work that showed the power of financial incentives when properly designed, really moving the needle on especially complex care journeys. And so what we've done is we've built a platform and a behavioral economics team that can bring the power of financial incentives to any type of care journey. What you see out in healthcare today really is pretty simplistic when it comes to rewards and financial incentives. There might be a one-time Amazon gift card for doing a primary care visit or a mammogram. We're taking this to an entirely different level. We have a team that can take any longitudinal care journey, like a diabetes management program or a diabetes prevention program, and build a roadmap, an easy digital roadmap for someone to follow. And the rewards get breadcrumbed along that path so that people see an opportunity to get healthy and get financial rewards at the same time. It draws them to sign up for the program at a much greater rate to begin with. And then with proper design of the financial incentives, you're actually with them every step of the way and encouraging them to continue their participation, whether the program is 3 weeks, 3 months, or 9 months. So what we've done is created as a link, whether it's diabetes, high-risk maternal health, COPD, any sort of care journey. We're not a clinical provider. We are an accelerant of the performance of specialized clinical care programs by getting more people active in the program and then helping them continue to be active throughout the program. And we do that as a managed service. We're not a technology company. We're a tech-enabled service, if you will. We handle all the administrative burden of reaching out to the eligible population, communicating the new opportunity to be healthy and earn rewards at the same time, sign them up, take them through the entire care journey. with the digital tools that we offer. We have a call center that helps people understand questions around the rewards or around the care journey itself. And then we do all the fulfillment of the rewards through a custom reward card that is a reloadable debit card that has certain parameters built into it that can be defined to any sort of level of specificity on where you can spend those reward dollars. We are really a custom program in terms of being able to customize towards any care journey, but also customize on the reward side in terms of building the right behavioral economics tools into the program, the right reward framing, the communications is all tailor-made, and then, as I said, the spending as well. So that complexity is what we really embrace, and we're a provider partner of this service throughout the life of the program. So very quick snapshots of the approach to our work. Again, we break down a complex care journey into very easy steps, very easy to follow. This is sort of what we call our clarification piece. A lot of people are intimidated by a long journey ahead of them on a particular condition, and we find it very helpful to break it down into simple, easy to digest steps and make it something that is visual and easy for someone to consume and understand. And then the motivation piece, everyone gets a reward card upon signing up, and the prospect of those rewards being delivered is a huge motivator as people go forward. But the design, not just the reward levels, but the design of the frameworks around each of the rewards is important as well. So we have a behavioral economics team that will look at the clinical care journey and break it down into steps and either bundle several steps together for a bigger reward or make incremental rewards for every step. Maybe consuming some video content allows you to earn a reward, or you might want to link that to a short quiz to make sure that people were really understanding and rewarding that content. And then the last piece is facilitation. So it's often one thing to show someone how they can earn a reward, show them what a great healthy step in their care journey might be, but often it's very debilitating for someone to take that next step and figure out how to actually complete that action. So where possible, we've built into the app that we deliver, it might be a map to the nearest LabCorp to get a screening. It might be a survey that we can serve up right there on the phone, or in the case of diabetes prevention, a short video on nutrition with diabetes and a quiz that follows. So wherever we can, we're actually serving up the next step in order to close that intention to complete an activity to the actual completion. And then we have a very sophisticated outreach platform. We have a way to be monitoring a very personalized journey for every member so that they are getting the nudges and reminders and encouragement throughout the journey, making sure that they're aware of the reward opportunities that are coming up or perhaps expiring so that they are motivated to complete every step in the journey. And then we have a call center that is available, multilingual, that allows people, even if they are not digitally native and comfortable with the app, they can certainly participate in all our programming just over the phone as well. And as was mentioned, we've been running this program for several years now in partnership with Highmark for the Medicaid population here in the state of Delaware. We've had excellent success in driving a very, very high level of participation. Many of the programs we run with Highmark are preventive around screenings and primary care visits, but we also run very specialized programs around chronic conditions or episodes of care. But these are just some very high-level benefits that we've been able to deliver. We put intention around understanding what are the particular goals of a program so that we can put emphasis on driving those. So some of these engagement metrics around really focus on cervical cancer screenings or primary care visits, those were highlighted as important, and we were able to put some extra effort into driving the communications and reward design towards those outcomes. But in general, what we're really proud of is the level of satisfaction and the level of overall participation that we've been able to drive with this very specialized rewards program. The digital outreach, the personalized outreach, the digital platform that allows people to participate at their own pace and see that roadmap in front of them, and then the reward design and the experience that they get with the rewards being delivered in real time, in some cases, right to that rewards card and getting a congratulations, there's now $20 new on your spending card. These are all contributing to very high levels of performance and satisfaction of the program overall. So for this program for state employees, this is being designed as a pilot. It's a small program focused on the pre-diabetic population, trying to drive higher levels of participation in the YMCA diabetes prevention program that was mentioned earlier. We are agnostic to the program, but we can work equally across Livongo or any of the other programs. But for this pilot, this population and this program was really identified as the best opportunity just to get a program in market, understand exactly what the dynamics were, and show exactly where we can move the needle on participation and follow through. This is just a sample timeline. In the work that we do, we have yet to get to the point of really identifying the specific curriculum that we want to accelerate adherence to. There's a planning meeting, I think, coming up very shortly where we would start to get into that level of work. This sample timeline is based on the YMCA Diabetes Prevention Program metrics and milestones that we actually ran for the Highmark Medicaid population. So we can take away and add new goals and measures and activities. But I just thought we'd put this in front of you so you could see sort of how we breadcrumb these rewards and break out the different steps in a program. And again, as that roadmap is laid out for the member, you would just click into any one of these activities and get the steps that it would take to get you either signed up, active, or participating in any one of those steps, or the food log, for example, that would be a form that you could fill out right on your computer or right on your phone and get that activity completed as you go through. So we're really trying to facilitate high levels of participation and completion. Don't need to go through this, but the point to get across here is that we are a service. So we have a team that is actually administering this program, monitoring it, actively supporting members as they move through the program. So there's a high level of service that gets associated with the program overall. It starts with outreach and awareness, a big campaign to make sure that people are understanding this new value proposition of getting healthy and getting rewards at the same time. Having that capability is very important around multiple programs that we run for Highmark. The enrollment process, very easy, can be done over the phone or through a phone or a computer. And then the engagement piece, the ongoing outreach, and a system that alerts people about an upcoming opportunity, a new opportunity, making sure they're aware of all the different steps. And then clearly reporting. We're very sort of ROI oriented and making sure that we're hitting all the milestones that were identified as important. Mitigating cost here, obviously, is the one that we're most focused on. And the budget for the program, it's a pilot, so the 3,200 is a broad population. We would be reaching out, engaging a small portion of that to make sure we were staying on task with the budget. But the overall program is performance-based. It has a projected rewards budget of $8,000. That amount is what would be paid out to the participating members as they move through the program. But that is a budget, and there are some things that can move around as we go through the design phase and assign different reward values and really get an understanding of how big that participating population we want to be funding, whether it's a larger population with a smaller dollar budget per member or something more targeted to try to really move the needle and hit very high levels of participation.
It's clear to Maddie's. Can you go back to that previous line on the dollar numbers? I want to understand what the GHIP would be charged. So the therapy subscription fee that's charged to the GHIP?
Yes, so everything above the line is a therapy fee. So therapy, there's subscription fee is for the platform itself that manages all the reward distribution and the app in the members' hands. Program development fee is a cost associated with building the program in the first place. And then the performance piece is just, we like to put a dynamic in any arrangement that we have that shows that we are putting, our work has to deliver in order for the full fee to be paid. So we would pick a target on either level of enrollment, activities completed, whatever metric makes you feel comfortable about really defining success, we would tie that last piece to that. And then below the line, there's the subtotal for that. And then below the line is $8,000 that would be also funded by you. That just goes in a side account. We have a third-party account for that rewards money that gets set aside. And then our system just delivers those funds, $10 and $20 at a time. As people go through the program, it gets loaded to their card. And so the full cost of the program is the bottom line, the $54,000.
And Secretary DeMatteis just wanted to also mention that as this is a partnership with Highmark, Highmark has given us permission to use our already established communication funds, or a small portion of our communication funds, to cover the cost of this one-year pilot, which includes all the details on the screen, so the implementation fees as well as the incentives, meaning there would be no additional cost to the GHIP for this pilot, and it would have no impact to the FY25 budget.
Okay, that's important. Thank you. It just seems to me, we've been trying to do so much for the past 5, 6, 7 years, and some of the Aetna programs have hundreds of people enrolled. Some of the other ones, like you said, have 18 enrolled. So it seems to me we're saying, well, let's see if we can throw some money at this and incentivize people to get some financial reward from it. I mean, it's just the reality that we've tried everything else. Will financial incentives move more people to participate? And Matthew, your experience in other states is that it does?
100%. And the best examples are right here in this state. We run different diabetes management programs in a couple of other states, in West Virginia and with MedStar in Washington, D.C. and Maryland. We have very high levels of participation in a diabetes management program that is much more intensive in terms of activities. The sort of typical norm, well, you were just stating numbers on the low level of participation that is unfortunately the norm in so many of these specialized programs that are offered. We wrote a white paper on the diabetes program. Those two programs in West Virginia and with MedStar in DC, we had over 75% participation rates on those programs. And the clinical evidence and the power of financial incentives is very strong. The complexity is delivering financial incentives on complex care journeys. And so that's what we've tried to solve for and really move the needle. And we've seen that across the board in lots of different programs, lots of different conditions.
Okay, Sean, you have a question?
Yeah, one, would you mind sharing the white paper with us?
Of course.
And two, so the report that we have on the participation in the YMCA program does include some statistics on sex, which shows low, it's disproportionately female participation, so therefore low male participation, which is my understanding is consistent with the experience with a lot of diabetes care management programs. You have high female participation, low male participation. can you say a little bit about what the experience has been in those other places in terms of the sex breakdown, and what it is that you've done to design programs in a way that overcome those differences?
Yeah, a lot of our work with Highmark Medicaid, large population, we see somewhat of the same breakdown, that same dynamic. I'm pulling up the white paper now so that because we did break it down by gender as well. But in that case, it had more to do with the roster of activities that were gender specific. There just being more opportunities for women than men. So therefore the potential for rewards was higher for women than men. I think we've tried to address this in a number of different ways. It depends how we are fed the data of the population we're serving. Sometimes we're fed the data in a way where we can see who's in a household. And there's a different way that you can engage a couple and a family that is more holistic, that can move the needle for low male participation. So there are lots of different ways that we can attack it. And unfortunately, my answer would be we need to know exactly what program we're looking to accelerate, exactly what population that we are looking to approach, and then we would tailor the communications program and the reward design to try to optimize around that. And going in, if we do see from your experience with the diabetes prevention program at the YMCA that there is that gender differential, then we can design to try to compensate for that.
Okay. And so the other programs you mentioned, were you just saying that those are Medicaid populations?
Yes.
Okay.
Yes.
So I mean, so what is your thinking going into this? Because we're not talking about a Medicaid population here. So how does the level of incentives differ, financial incentives differ by income level in terms of take up rate? Do we, any insights into that? Because obviously Medicaid is generally a lower income population.
Sure. Well, we have a behavioral economics team. We're happy to share the research. The efficacy of financial incentives is pretty universal. You're right. If you're of extremely high income, you would need to trend towards some higher level of reward in order to move the needle. And as I said, we're very sort of ROI oriented in our design. So we would have a cap on where we thought you were losing the effectiveness of the return on a financial reward if it were getting too high. But I can guarantee you that we're nowhere near that with the population that you are serving, with the evidence that is not just from our own research, but the clinical research around this. A few $100s of financial incentives will move the needle on human behavior if it is framed the right way and set up the right way, especially because the motivations, everybody wants to be healthy. It is quite often the obstacles to them getting to healthy that are in the way. There's either a mistrust of the medical community or confusion of the program itself, or some sort of resistance around access to care. There's just a hurdle in someone's mind. And so if you help them overcome those initial hurdles with the financial incentives, they want to be healthy already. So you're really just motivating them to get uncomfortable a little bit as they go to the doctor for the first time or go to that first class, or show them a roadmap that makes it easier. So it isn't just a financial incentive. It's building an easy, more inviting journey in front of them, adding the financial incentive, and then getting them motivated to take those first initial steps. And I think that is universal. It's not really tied directly to income unless you're starting to get into the very high income brackets.
And Matthew, if you'll send us a link or send us that white paper, we'll make sure that the members get it. And Josette, you have a question, Secretary Manning. Did I lose you, Secretary Manning? I think I did.
I'm sorry, can you hear me now?
Yes.
Yep.
Okay, sorry. I believe, and I rely on my DHR friends for this historical information, but I don't remember when. I've been with the state almost 25 years. So sometime in the last 25 years, definitely at least 10 years ago, we had a program with some financial incentives. And I believe back then the ballpark was $250. I remember being at DOJ and participating in it on some level. So while I love that sounds like it's risk-free and cost-free to the state, I think that's great. I think it would be helpful if we understood what we did before and how we did it and why that didn't continue. And it could have just been financial reasons it didn't continue. But to avoid, repeating the same mistakes, it might be good to get that history.
That's a good point. And Faith has a little bit of that history.
Yeah, Secretary Manning, you have a very good memory. You are correct. The program was very different in the sense that the rewards that were paid to the participants was not real time as what we're proposing here. Participation was not what we would have hoped. We discontinued the program, but the largest feedback we received from program participants was they really didn't like that long wait time to receive those payouts. They were only paid out, I think maybe once or twice a year. So we really feel like this model is going to be more effective because folks are going to see those rewards coming in as they're, achieving the various goals and objectives.
Yeah. So this is all good information. We will take it under advisement and have it on the agenda again next month for a potential further discussion and vote on whether we would want to move forward with this pilot. Due to time, we are going to move the Highmark non-Medicare virtual health program presentation to next month. And we will move to an update on audit services from Faith.
Yes, thank you, Secretary. So I just very briefly, I wanted to share with the committee, following your approval at the September 23rd meeting on the scope of work for the audit request for proposals, our office was contacted by the Auditor of Accounts expressing interest in reviewing that scope and participating in that RFP process. So we are currently engaging with the Auditor of Accounts office. We've provided them with a draft of the RFP, and we are expecting to receive comments from them no later than November 18th. And this is really to get their feedback and suggestions on how that RFP and specifically that scope of work and the various qualifications that we're asking of bidders in this RFP process, that to the extent it makes sense, if there can be better alignment with government auditing standards specific to performance audits, which is really the kind of audits that we've traditionally contracted for under prior and similar RFPs. They would like to provide feedback on that. So we are awaiting that feedback and guidance from their office. To the extent it in any way changes the scope of work that you approved in September, we'd like to bring that back before you when you meet on November 25th and just ask for your consideration and approval for any changes in that scope. We were targeting a release of the RFP at the end of October. We've now extended that based on this engagement with the Auditor of Accounts to late December. And we still feel confident that we can work within that time frame should we have any changes in that scope of work as a result of their input. And then lastly, I just wanted to share with you, they have also offered to participate in that overall RFP process and will be designating a representative to serve on that proposal review committee. So we thought that was really helpful as well to have their guidance.
Sure, it's a good practice. Appreciate that update. We will now move into executive session to review a level 3 disability appeal. May I have a motion to move into executive session?
So moved.
Thank you.
Seconded.
Thank you. All in favor, signify by saying aye.
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 Any abstentions? Okay, we'll see you in the other link that we provided in 30 seconds.
Ladies, thank you so much.
Thank you very much.
Informative afternoon session.
Thank you, appreciate that.
Well, having been here since the Tatman building, I've been in Texas, I just moved back. So,
Thank you very much.
thank you.
We'll see you November 25th.
Yes, ma'am.
Yes. Okay, we're back in public session. And as we're waiting for everybody to rejoin, I will say that Carol will send out a note for the November meeting, November 25th. We do have some extra items on that agenda, so I'm going to request that we extend it by 30 minutes. We'll send out a note to see if you want to extend it on the front end to start at 1:30 or on the back end to go till 4:30. But I don't think it's conducive to try and rush through some of these topics. We just need some extra time in November. Do we have a quorum, Carol?
We do have a quorum.
All right. Coming out of executive session, I will entertain a motion to accept the recommendation to extend the short-term disability benefits as requested from May 13th, 2024 through June 5th, 2024.
So moved.
Seconded.
Any further discussion? Hearing none, all in favor signify by saying aye.
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 Are there any opposed? Are there any abstentions? The motion is carried and approved. That concludes our October meeting. Look out for the request for November. Again, our November meeting is November 25th. Thank you all for your time. Enjoy Halloween. Enjoy this wonderful summer weather. We'll see you in November. Thank you.
Take care.
Thanks,
so
everybody.
much.
Approved. Approved. We're adjourned.